Nipro, your partner in healthcare.
Hi, good day, everyone. Welcome to World Congress of Nephrology 2022 Industrial Symposium by Nipro. I'm Soo Kun, a nephrologist from Malaysia. Next. So this is a simple agenda for this particular session. The topic is on super high flux dialyzer and mortality in hemodialysis patient. We are going to start out with the lecture by Professor Masanori Abe, followed by a panel discussion. I'm going to introduce the panel in a short while. Next. Let us look at the learning objective for this particular session. We hope at the end of the session, the participant will be updated on the current status of dialysis patient, choice of dialysis membrane for improved clinical outcome, effect of different synthetic dialyzer membrane on mortality on patient on hemodialysis, dialyzer classification and mortality in patient on hemodialysis, and Elisio HX super high flux dialyzer and its latest evidence. Next. So we have three panel members. So first is our speaker, Professor Masanori Abe. I'm going to address him as Professor Abe in the session. He is from Nihon University School of Medicine, Japan. He's a professor and chairman of a division of nephrology, hypertension, and endocrinology. He specializes in hemodialysis with more than 200 publications. Next, Professor Pham Van Bui. I'm going to address him as Professor Bui. He is from Pham Ngoc Thach University of Medicine, Ho Chi Minh City, Vietnam. He's professor and head of the nephrology, urology, and transplantation department. He's pioneer in chronic peritoneal dialysis and maintenance hemodialysis in Vietnam. Professor Khajohn Tiranathanagul. I'm going to address him as Professor Khajohn. He's from Chulalongkorn University, Thailand. He specializes in kidney replacement therapy, kidney disease, and has been author for international and local textbooks. So without further ado, I would like to invite Professor Abe to deliver his talk on super high flux dialyzer and mortality in patients on hemodialysis. Professor Abe, the floor is yours.
Ladies and gentlemen, I'm Masanori Abe from Nihon University in Tokyo, Japan. I'd like to thank the WCN organizing committee for inviting me to speak here today. I'll be talking about super high flux dialyzers and mortality in hemodialysis in Japan. This is my COI. First, I'd like to outline the characteristics of dialysis patients in Japan and then discuss what type of dialysis membrane should be used. I'll compare the effects of the different synthetic dialyzer membranes on mortality in these patients, as well as the relationship between dialyzer classification and mortality. First, let's look at the characteristics of dialysis patients in Japan. The Japanese population is aging rapidly, and there's a growing number of patients with end-stage kidney disease on dialysis. Even though Japan is small in size, it has many hemodialysis facilities and clinics, particularly in Tokyo. Many patients use the transportation service provided by their hemodialysis facility to attend sessions, although most patients at our acute care tertiary hospital are likely to enter the hemodialysis room on a stretcher. The prognosis of dialysis patients in Japan is among the best in the world. However, I do have some concerns. The number of patients with primary diabetic nephropathy initiating dialysis continues to increase. In Japan, the major cause of chronic kidney disease, CKD, is hypertensive nephrosclerosis, which is caused by long-term hypertension and atherosclerosis. Japan has the highest rate of population aging in the world. which is why we are seeing an increase in nephrosclerosis. Patients with diabetes are also aging, and it has been reported that half of these patients in Japan are over 70 years old. To prevent end-stage kidney disease, the main disease to target are diabetic nephropathy and the ever-increasing nephrosclerosis. This figure shows the breakdown of dialysis patients in Japan according to age group. If we define the elderly as age 65 years or older, 67.9% of these patients would be considered elderly. Furthermore, patients aged 75 years or older account for 35%. Fortunately, the number of younger patients has been decreasing recently. The prognosis of patients on dialysis in Japan has been improving. As of the end of 2018, the mean duration of maintenance dialysis was 6.8 years overall. The number of patients on dialysis for longer durations has been increasing, with 27.7% now having been on dialysis for 10 or more years. The proportion of patients with a dialysis duration of 20 years or more was less than 1% at the end of 1992, but reached 8.4% at the end of 2018. There were approximately 340,000 patients on chronic dialysis in Japan as of the end of 2018. Japan has the second highest prevalence rate of dialysis patients in the world, behind only Taiwan. Hemodialysis was a modality used in 97.2% of Japanese patients in 2018. Conventional hemodialysis was used in 60%, followed by hemodiafiltration in 37%, home-based hemodialysis in 0.2%, and peritoneal dialysis in 2.8%. Of these, about 20% on peritoneal dialysis were treated with a combination of peritoneal dialysis and hemodialysis or hemodiafiltration. The KDOQI guideline advises against the use of poorly biocompatible cellulose membranes, whereas the European guideline recommends using highly biocompatible high-flux membranes with large pores to decrease morbidity and mortality, and avoiding dialysis membranes that strongly activate complements, white blood cells, and inflammatory responses. Meanwhile, the Japanese Society for Dialysis Therapy, JSTT, recommends the use of high-performance membrane dialyzers, or HPM dialyzers for short. Researchers have recently reported that beta-2 microglobulin, beta-2-mg, is not only a uremic toxin that should be removed, but also a predictor of prognosis in patients on dialysis. 1 year mortality was compared between a group with a beta-2-mg level of less than 25 mg per liter and a group with a level of 30 mg per liter or higher, using a group with a pre-dialysis beta-2-mg level of 25 to 30 mg per liter as a reference. The mortality rate increased with increasing pre-dialysis beta-2-mg level. Therefore, a higher pre-dialysis serum beta-2-mg level was associated with mortality. The recommended dialysis conditions are intended to achieve a maximum pre-dialysis beta-2-mg level of less than 30 mg per liter. Furthermore, decreasing the concentrations of substances larger than beta-2-mg may improve prognosis. To achieve this goal, we must consider the dialyzer membrane. This is the Japanese classification for dialyzers. A type 1 dialyzer is classified as low flux. types 2 and 3 as high flux, and types 4 and 5 as super high flux. HPM dialyzers are defined as having high hydraulic and solute permeability, particularly for middle molecular weight molecules, and uremic toxins with a molecular weight of 10,000 to 30,000 daltons, high biocompatibility, and a beta-2 mg clearance rate of more than 50 milliliters per minute. These dialyzers target uremic toxins of a relatively high molecular weight that cannot be removed by conventional dialyzers. The pores in these membranes are larger than those in high-flux membranes, which means that HPM dialyzers can remove small, medium, and large molecules, including low molecular weight proteins and small amounts of albumin. The optimal pore size should prevent loss of more than 3 grams of albumin per session using a standard hemodialysis procedure in Japan, which includes a blood flow rate of 200 milliliters per minute and a dialysate flow rate of 500 milliliters per minute. Synthetic polymeric membranes were first developed in the late 1960s and are now widely used. Most of these membranes have high permeability and are known as high-flux membranes. In Japan, the concept of the HPM became popular in the early 1980s. The HPM was originally developed to eliminate middle molecular weight substances which previously could not be eliminated by cellulosic membranes. So the main purpose of the HPM came to the eliminating uremic substances with a molecular weight of 10,000 to 30,000 daltons. The HPM concept includes 3 characteristics, namely 1, high permeability, 2, high solute permeability, especially for middle molecules, and 3, high biocompatibility. As shown in this table, low-flux dialyzers are defined by an ultrafiltration rate of less than 20 milliliters per millimeter mercury per hour, and a beta-2 mg clearance rate of less than 20 milliliters per minute, while high-flux dialyzers are defined by an ultrafiltration rate of 30 or more and a beta-2 mg clearance rate of at least 40. However, before 2016, dialyzers in Japan were classified as types 1 to 5 based on beta-2 mg clearance rates of less than 10, less than 30, less than 50, less than 70, and greater than 70 milliliters per minute at a blood flow rate of 200 milliliters per minute and a dialysate flow rate of 500 milliliters per minute. Types 4 and 5 are classified as super high flux membranes or HPM, high performance membrane dialyzers, and are used for more than 90% of hemodialysis patients in Japan. In 2016, dialyzers in Japan were reclassified as shown in the lower table. Nowadays, many patients are treated with HPM or super high flux dialyzers in Japan. Another classification was recently proposed. As shown in this table, dialyzers are now classified into 5 categories: low flux, high flux, medium cutoff, protein leaking, and high cutoff. In Japan, type 4 and 5 dialyzers or super high flux dialyzers correspond to the medium cutoff or protein leaking category. Next, what type of dialysis membrane should be used? There are 7 types of HPM dialyzers in Japan. However, there is little information available regarding which type of dialyzer results in the best prognosis. Therefore, we conducted a cohort study using data from a nationwide registry of hemodialysis patients in Japan to determine the association between the different types of dialyzers and 2-year mortality rate. The 7 types of dialyzer materials used in Japan are cellulose triacetate, CTA, ethylene vinyl alcohol, EVAL, polyacrylonitrile, PAN, polyester polymer alloy, PEPA, polyethyl sulfone, PES, polymethyl methacrylate, PMMA, and polysulfone, PS. Data were obtained from the annual nationwide surveys of hemodialysis patients conducted by the JSDT. First, models were analyzed after adjustment for the following basic factors measured at baseline: age, sex, duration of dialysis, and cause of end-stage kidney disease. In addition to basic factors, models were analyzed after adjustment for dialysis dose, KT above B, and the beta-2 mg level. Finally, models were analyzed after further adjustment for the following nutrition-related factors: normalized protein catabolic rate, NPCR, serum albumin level, total cholesterol level, body mass index, BMI, and percent creatinine generation rate, percent CGR, in addition to basic factors and dialysis dose. We also adjusted for significant differences in baseline covariates using propensity score matching. The scores were then used to match patients treated with a PES membrane as a reference with patients treated with the other membranes in a 1:1 ratio. The study population consisted of patients on maintenance dialysis between December 2010 and December 2012. Overall, 309,000 patients were registered as of the end of 2010. After exclusions, data were available for 136,000 patients. Over half of the patients, that is 57%, underwent hemodialysis with PES membrane, followed by PES 15.1%, CTA 14.3%, PEPA 7.4%, PMMA 3.8%, PAN 1.5%, and EVAL 0.9%. The patients were divided into 7 groups according to the type of dialyzer membrane material used. The demographics and clinical characteristics of each group are shown in this table. Patients treated with EVAL were older and more likely to be female and have a shorter hemodialysis duration, a higher cardiovascular comorbidity rates, and poor nutritional status. On the other hand, PS and PES membranes were associated with younger age, male sex, lower rates of diabetes and cardiovascular disease (CVD), and higher dialysis dose, NPCR, and percent CGR. The data are adjusted using basic factors with the PS as the reference group. The hazard ratios were significantly higher in the CTA, PMMA, PAN, and EVAL group. Further data adjusted for dialysis dose yielded the same results as those obtained when the data were adjusted for basic factors. After further adjusted for nutrition-related and inflammation-related factors, the hazard ratios were significantly lower for the PES and PMMA groups than for the PS group, with respective values of 0.88 and 0.84. This table shows patient characteristics and baseline data in the PS group and each corresponding group after propensity score matching. There were no significant differences in any variables between the PS group and the CTA, EBAR, and PAN groups, or between the PS group and the PEPA, PES, and PMMA groups. Here are the results. There were no significant differences in hazard ratios between the CTA, EBAR, and PEPA groups and the PS groups. The hazard ratios were significantly lower for the PMMA and PES groups compared with the PS group. Our findings suggest that the type of membrane used may affect mortality. Further long-term prospective studies are needed to clarify whether the PES and PMMA membranes can improve prognosis. Biocompatibility and efficiency of solute removal are important considerations in patients on hemodialysis. Improved biocompatibility is expected to prevent dialysis-related complications such as arteriosclerosis and malnutrition, and to delay disease progression by alleviating microinflammation. The biocompatibility of dialyzers is greatly influenced by the interaction between blood and the treatment materials, the chemical and physical characteristics of which play an important role. Malnutrition in dialysis patients results from a complex interplay of various factors, such as accumulation of uremic toxins, weak inflammatory responses caused by poor biocompatibility of dialysis treatments, poor appetite, and nutrition loss during dialysis. Major factors associated with biocompatibility are reactions with materials, including the dialyzer membrane, reactions with the dialysate, including endotoxins and bacterial contaminants, and the internal pressure and blood flow velocity into the portal fibers. Many PS membranes contain polyvinyl pyrrolidine, PVP, which is incorporated into the membrane in varying amounts to both increase hydrophobicity and to control the flux characteristics to the membrane. The biocompatibility of PS membranes varies according to the amount of PVP added, as well as other factors. Recent studies suggest that PS is also associated with unpleasant side effects, including anaphylaxis and skin lesions, supposedly caused by PVP. Therefore, biocompatibility, lack of toxicity from the chemical components of the dialysis membrane, and a broad, well-balanced removal pattern of uremic toxins are essential basic scientific requirements for patient satisfaction. Bisphenol A, BPA, is a component of some dialysis membranes and accumulates in patients with CKD. Observational studies have linked BPA exposure to kidney and cardiovascular injury in humans, and animal studies have demonstrated a causative link. Normal kidneys excrete BPA rapidly, but insufficient excretion may render patients with CKD prone to the adverse effects of this compound. These are results from a cross-sectional analysis of BPA concentrations and health status in the general adult population in the United States. Higher urinary BPA concentrations were associated with cardiovascular disease and diabetes. Higher BPA exposure reflected in higher urinary BPA concentrations may be associated with avoidable morbidity in the community-dwelling adult population. This cross-sectional study included 152 prevalent patients with CKD in whom the plasma BPA level started to rise after stage 3 of CKD. BPA concentrations were more than 6 times higher in patients on maintenance hemodialysis than in those with stage 5 not yet on dialysis. In this study, there was a strong inverse correlation between BPA concentration and residual kidney function. The upper panel shows the serum BPA level before and after a single hemodialysis session when using PS and PES dialyzers. Mean BPA levels increased from 46.3 to 78.4 nanograms per milliliter. In other words, a 68% increase over the pre-dialysis baseline value following a single hemodialysis session with a PS dialyzer, whereas no changes were observed with a PES dialyzer. The lower panel shows that the mean pre-dialysis serum BPA level tended to increase with continuous use of a PES membrane for 3 months. By contrast, continuous use of a PES membrane for 3 months decreased the mean pre-dialysis serum BPA. PMMA is symmetrical membrane in which the whole thickness is involved in the separation process, allowing high efficiency adsorption of both middle and high molecular weight molecules, such as beta-2-Mg, free light chains, and inflammatory cytokines. PES membranes are a variant of PS and are designed for better clearance of high molecular weight toxins while restricting passage of albumin. Depending on the mode of modification, PES membranes may be more biocompatible than PS membranes, based on degree of leukopenia and platelet adhesion. The most recent generation of PES membranes has the best biocompatibility characteristics and an excellent ability to remove low molecular weight proteins as a result of outstanding perm selectivity. Finally, I'd like to discuss dialyzer classification and mortality in hemodialysis patients. The results of the HEMO study, which was a large randomized control study, were reported in 2002. There was no significant difference in mortality between low flux and high flux dialyzers. Increases in dialysis dose and clearance of small molecular weight substances were not associated with improved outcomes in hemodialysis patients in this study. However, the high flux dialyzers were found to be superior in subgroup analysis. High flux dialyzers were associated with a significantly better survival than low flux dialyzers in patients with a longer dialysis duration, namely more than 3.7 years. After adjustment for residual kidney function and duration of dialysis, the pre-hemodialysis beta-2-Mg level was found to be an independent predictor of mortality. The results of the 4D study were reported in 2007. Mortality was greater with cellulosic low-flux semi-synthetic and low-flux synthetic membranes than with high-flux synthetic membranes. These data suggest that the permeability and biocompatibility of the membrane may have an impact on mortality in patients with type 2 diabetes on hemodialysis. Another large randomized control study known as a Membrane Permeability Outcome Study, MPO study, showed that high flux dialyzers were associated with significantly better survival than low flux dialyzers in patients with diabetes or serum albumin levels less than 4 grams per deciliter. COSMOS was a multi-center open cohort 3-year prospective study that was designed to evaluate mineral and bone disorders in the European hemodialysis population. After adjustments using 3 different multivariate models, patients treated with high-flux membranes had lower all-cause and cardiovascular mortality rates, which remained significant for all-cause mortality after propensity score matching. However, a facility-level analysis showed no association between the case mix adjusted facility percentage of patients dialyzed with high-flux membranes and all-cause or cardiovascular mortality. Furthermore, a meta-analysis found that cardiovascular mortality, which is a major cause of death in dialysis patients, was reduced in patients treated with high-flux dialyzers. A systematic review also found that high-flux dialyzers had significant benefits in terms of all-cause mortality for certain pre-specified conditions, such as a serum albumin level less than 4 grams per deciliter, a hemodialysis duration of more than 3.7 years, and the presence of diabetes or arteriovenous fistula. However, these findings are not applicable in Japan because we are already using super high-flux membranes. Dialyzers are classified as low flux, high flux, and protein leaking internationally, and as types 1 to 5 based on the beta-2 mg clearance rate in Japan. Type 1 dialyzers correspond to low flux dialyzers, types 2 and 3 to high flux dialyzers, and types 4 and 5 to super high flux dialyzers. In this nationwide retrospective cohort study, we aim to clarify the association of type of dialyzer with mortality by analyzing data from the JSTT Renal Data Registry from 2008 to 2011. We enrolled 242,000 patients on hemodialysis and divided them into type 1 to 5 groups using the Japanese classification. We assessed the association of each group with 3-year all-cause mortality using Cox proportional hazard models and performed propensity score matching analysis. Most patients received hemodialysis with a type 4 dialyzer, 81.2%. Followed by type 5, 12.3%, type 3, 4.2%, type 1, 1.3%, and type 2, 1.0%. Patients treated with a type 1 dialyzer were older, more likely to be female, to have higher rates of comorbid cardiovascular disease and diabetes, and to have a lower BMI. In contrast, patients treated with type 5 dialyzers were younger, more likely to be male, to have lower rates of comorbid cardiovascular disease and diabetes, and to have a higher dialysis dose and higher NPCR and %CGR values. Kaplan-Meier analysis showed that survival deteriorated steadily from dialyzer type 1 to 4. Compared with the type 4 group, which was a reference group. The type 1, 2, and 3 groups showed unadjusted hazard ratios for all-cause mortality of 2.4, 1.7, and 1.2 respectively. Type 5 group had a significantly lower hazard ratio of 0.65. After adjustment for basic factors, dialysis dose, and nutrition and inflammation-related factors, the hazard ratio for the type 3 group did not differ significantly from that for the type 4 group. Although type 1 and type 2 groups had significantly higher hazard ratios, and the type 5 group had a lower hazard ratio. This table shows the patient characteristics and baseline data in the type 4 group and each corresponding group after propensity score matching. There were no significant differences in any of the variables between the type 4 group and type 1 and type 2 groups. There were also no significant differences in any variables between the type 4 group and type 3 and type 5 groups. Compared with the type 4 group, the hazard ratio was significantly higher in the type 1 group, not significantly different in the type 2 and type 3 groups, and significantly lower in the type 5 group. Type of dialyzer classified by the beta-2 mg clearance rate was significantly associated with 3-year mortality in this large nationwide cohort study of Japanese patients on dialysis. Our findings indicate that super high-flux dialyzers might be beneficial for patients on hemodialysis. Although the type 4 and 5 dialyzers are both classified as super high-flux dialyzers, this study indicates that the type 5 dialyzers are superior in terms of performance. To confirm the reproducibility of our findings, we performed a cohort study that analyzed data from the JSDT renal data registry from 2010 to 2013. We performed 2 subgroup analyses. First, the dialyzers were classified as low flux, high flux, and super high flux or protein leaking dialyzers using the international definition. Next, the dialyzers were classified as type 1, 2, 3, 4, or 5 based on the beta-2 mg clearance rate according to the Japanese classification. Type 1 dialyzers corresponded to low flux, types 2 and 3 to high flux, and types 4 and 5 to super high flux or protein leaking dialyzers. We enrolled 238,000 patients on hemodialysis in this study and assessed the association of each group with 3-year all-cause mortality after propensity score matching. This table shows the patient demographics and characteristics of each dialyzer group in the subgroup analysis based on the international classification. Most patients received hemodialysis with super high flux dialyzers, 95.6%, followed by high flux dialyzers, 3.4%, and low flux dialyzers, 1.0%. Patients treated with using low flux dialyzers were more likely to be older and female, to have higher rates of comorbid cardiovascular disease and diabetes, and to have a lower BMI. In contrast, patients treated using super high flux dialyzers were younger, more likely to be male, and had lower rates of comorbid CVD and diabetes, and higher dialysis dose and PCR and percent CGR values. Kaplan-Meier analysis showed that survival deteriorated steadily as the type of dialyzer increased. Compared with the high flux dialyzer group, the reference group, the low flux dialyzer group had a higher unadjusted hazard ratio for all-cause mortality of 1.88. In contrast, the super high flux dialyzer group showed a lower unadjusted hazard ratio for all-cause mortality of 0.78. This figure shows the adjusted hazard ratios for all-cause mortality in each group. After adjustment for basic factors, including age, sex, duration of dialysis, history of CVD, and diabetes status, the hazard ratio was 1.47 for the low flux group and 0.83 for the super high flux group. After adjustment for basic and dialysis-related factors, including dialysis dose Khajohn and the beta-2 mg level, the hazard ratio was 1.20 in the low flux group and 0.89 in the super high flux group. Finally, after adjustment for basic factors, dialysis-related factors, and nutrition and inflammation-related factors, including BMI, hemoglobin, and PCR, percent CGR, and serum albumin, and CRP levels, the low flux group had a significantly higher hazard ratio of 1.12, whereas the super high flux group had a lower hazard ratio of 0.95. Patients treated with high flux dialyzers were matched with those treated with other types of dialyzers in a 1-to-1 ratio according to propensity score. Compared with the high flux group, the low flux group had a higher hazard ratio. However, the super high flux group had a significantly lower hazard ratio. This table shows the patient demographics and characteristics in each dialyzer group according to the Japanese classification. Most patients received hemodialysis with type 4 dialyzers, 74.3%, followed by type 5, 21.3%, type 3, 2.4%, type 2, 1.0%, and type 1, 1.0%. Patients treated using type 1 dialyzers were older and more likely to be female and had higher rates of comorbid cardiovascular disease and diabetes, and lower BMI. In contrast, patients treated using type 5 dialyzers were younger and more likely to be male and had lower rates of comorbid cardiovascular disease and diabetes and higher dialysis dose, Khajohn, and PCR and percent CGR. Kaplan-Meier analysis showed that survival steadily deteriorated as dialyzer type increased, except for type 5. The type 5 group had a significantly lower hazard ratio of 0.64. During the 627,538 person-years of follow-up, the mortality rate was significantly and consistently lower in the groups with dialyzers providing higher beta-2 mg clearance. This figure shows the adjusted hazard ratios for all-cause mortality in each group. After adjustment for basic dialysis-related and nutrition-related and inflammation-related factors, the hazard ratio for the type 3 group was not significantly different from that for the type 4 group, but was significantly higher at 1.1 for both the type 1 and type 2 groups, and significantly lower at 0.91 for the type 5 group. Patients who were treated with a type 4 dialyzer were propensity score matched with those treated with other types of dialyzers in 1-to-1 ratio. As shown in this figure, there were no significant differences in the hazard ratio between the type 4 group and any other groups. However, the hazard ratio was significantly lower in the type 5 group. Elisio HX PES membrane is one of the super high flux dialyzers. There are three key concepts. First, excellent removal in solute removal. Second, high removal of low molecular weight protein. Third, low protein leakage. This dialyzer is included in type 5 dialyzers in Japanese classification. This study compared Elisio HX to a medium cutoff membrane. There was no significant difference in clearance rate of small substances and low molecular weight protein between the two groups. However, albumin leakage is significantly lower in the Elisio HX group. This dialyzer may be beneficial for patients on hemodialysis. In summary, today I discussed the current status of patients on dialysis in Japan. The Japanese Society for Dialysis Therapy recommends the use of super high flux dialyzers. PES and PMMA membranes may improve prognosis, but long-term prospective studies are needed to clarify whether this is the case. Super high flux dialyzers, which include type 4 and type 5 dialyzers, might be beneficial for patients on hemodialysis. Our research indicates the superiority of the type 5 dialyzer, and further large-scale randomized controlled trials are needed to confirm this. Thank you for your attention.
Nipro, your partner in healthcare.